Hello, everyone. Thank you very, very much for joining us today. We will be starting in about 14 minutes from now. Please feel free to share your questions and your comments in the chat box, and I will be so happy to take them all up one by one in the discussion during the discussion session. I hope you know about news webinar series collection, all those recordings that have been, all those webinars that have been conducted by me during the past. I think more than 2 years. So all of these, almost all of these are available on my YouTube channel. Please feel free to subscribe to my YouTube channel. And also please visit my official website, the newsneuro.xyz. I will be so happy to see you all on this website. I have got several Western Lanzino here. Good morning, sir. Good morning, sir.
Good morning. Good morning.
Thank you very, very much, sir, for joining us today on Saturday and at such an early hour. It's so kind of you, sir.
You're welcome. You're welcome. Getting some coffee so to wake up.
Thank you very, very much, sir. So kind of you. So we are virtually sharing, yeah, like a very good time and a very good class and oh my God, I guess my camera has been I'm sorry, it has been turned off. Thank you very, very much, sir. It's so good to see you here and welcome you again to the news webinar series.
Let me check. Let me check my screen and make sure that you can see my screen, right?
Yes, sir. We can see your screen. I can see your screen very clearly, sir. Sir,
Okay.
would you like to check your your videos? Would you like to, if you have got them in
Yeah,
the,
let's see. You can see?
yes, sir. It's quite perfectly. We can
Okay.
see it goes perfectly. Thank you very, very much.
Good.
Sir, thank you very much for joining us today, sir. We are all huge fan of your work. Everyone who is interested in cerebrovascular surgery knows you so well, and we are always reading your work, especially myself. I had the pleasure of presenting during several of the Link Asia conferences, and I always would quote references from your work, and it was so amazing. And I'm so deeply impressed by all your work. You are such a inspiration for all of us.
Thank you. Thank you for your kind words.
Sir, I guess the attendees are joining us slowly, and as soon as they get to know that
Yeah,
the
that's
webinar.
fine.
Yes.
I will try to um, I'm trying to transfer a couple of more videos while we are waiting, okay?
Thank you very much, sir. Sure. I guess that everyone is in the process of joining the webinar. Sir, I've got live attendees on my YouTube channel, and also Dr. John Bennett is also broadcasting it live on neurosurgical.tv. Sir, we will start the webinar whenever you will be feeling comfortable with. So we will be so happy to start at your convenience.
I'm ready.
Thank you very, very much, sir. It's a matter of real honor and joy for me to introduce to have the privilege of having you again for the news webinar series, sir. Again, I want to really express our gratitude to you for your dedication towards neurosurgical education, sir. It's a real honor to have you again with us. You are a huge inspiration for all of us, especially those who are interested in cerebrovascular neurosurgery. So you are like a huge inspiration for all of us. So again, thank you very much for sparing time from your very busy schedule. And I believe that it's obvious that Professor Giuseppe Lanzino doesn't require any introduction, but for the sake of formality, I'm pleased to give a few short lines. Professor Giuseppe Lanzino is a very famous neurosurgeon. He's a professor of neurosurgery at the Mayo Clinic in Rochester, Minnesota, and he has a huge contribution in the neurosurgical. You can see, you can go through his works, and each one of us have certainly read his papers. He has penned down about I think 300 papers, other than co-author several of the papers, has taken part in several of the large studies, and also Professor Lanzino has authored 4 textbooks of, which you might have already read about, but for the sake of formality, I'm just pleased to mention about this. So it's a real honor for me to introduce you. Sir, thank you very much for sparing your time, especially on a Saturday morning, it is such an early hour. So again, thank you very much. Professor Lanzino will be sharing a lecture on intracranial dural arteriovenous fistulas. Sir, welcome again to the webinar. Thank you very, very much again, sir. It's an honor to have you again. The floor is all yours now.
Thank you. Thank you very much for the kind introduction. And the topic of today is dural AV fistula. And this is a very important topic because they might not be very common, but it's definitely a relatively common type of pathology that is encountered by neurosurgeons, especially if they have an interest in cerebrovascular disease. More importantly, they can be a little bit difficult to diagnose at first because the pathophysiology of dural AV fistula is often related to uh, to venous outflow issues. And when we have venous outflow issues, the symptoms can be very different. And I say that patients with dural AV fistulas can present with any combination of neurological and non-neurological signs and symptoms known to mankind. And the reason is that while for the arterial system, it's fairly predictable the areas that can be involved if there is, for example, an occlusion of the left middle cerebral artery, the symptoms will reflect a compromise of movement on the right side of the body, and in patients with left side dominance speech problems. So the arterial side, we know a lot about the distribution and the functions, and therefore symptoms can be quite predictable. But when there is involvement of venous outflow, then because of the different combination of networks, venous networks in different people, then the symptoms can be quite variable. Now, here at the Mayo Clinic, we have a strong tradition in the treatment of dural AV fistula. And this paper that was published about 40 years ago gives us a way to realize the progress that we have made in the treatment of these lesions. In this report by Dr. Sant and Pipgras, there were actually a couple of patients who died on the operative table because of massive bleeding just turning the craniotomy. So that, as I said, that gives us a little bit of a historical perspective of how much we have progressed. And nowadays, when we consider treatment of a dural AV fistula, we have different modalities: embolization, stereotactic radiosurgery, surgery, and observation. It's important always to realize that, especially when we deal with unruptured lesions. And nowadays, more and more, we deal with lesions that are diagnosed incidentally. Then we always have to consider the fact that observation and careful follow-up is often a valuable option. So when we look at a dural AV fistula, what are the factors that affect our treatment? And this is something, this is a overall, these are general considerations that apply not only to dural AV fistula, but also to other cerebrovascular disease. So symptoms, of course, it's a very important factor. The angioarchitecture of the lesion tells us about a lot about the potential natural history. The location is important because it's also often correlated to the symptoms and angioarchitecture. So often all these factors are somehow interconnected. So let's look at some examples. This is a 41-year-old who presented with sudden onset of headache, decreased loss of consciousness, and eventually coma. And you can see here on the CTA what you notice that there are probably dilated vascular structures, but you can see how they are sparse. And then there is a draining vein, and this is probably the site of the fistula, because in dural AV fistula, the location of the fistula, the arteriovenous shunt, it's, as the name implies, it's at the level of the dura. And once you learn that you can see that these dural AV fistulas have a very specific pattern. For example, this is would be classified as a lateral tentorial dural AV fistula. And this lateral tentorial dural AV fistula, the arteriovenous shunt is along the petrous ridge, and the arterialized draining vein emerges from the dura at the level of the petrosal system. So it's the arterialized dural AV, the arterialized vein in these particular patients is nothing but an arterialized petrosal vein. So in this particular case, the draining vein, there is a retrograde drainage, drains superiorly, you can see, and eventually empties into the straight sinus. So you can see that as you follow the vein. And here you see something that is very common in dural AV fistula, and it's an important point to stress, is that, as you recall, the point of fistula is here along the Petrus ridge when the vein emerges from the dura. But as you can see in these patients, the source of the hemorrhage is actually distal from the actual point of fistulization. And here you can see the venous varix, and you can see better on the coronal reconstructions where the venous varix, which is the point of rupture, and you can see how the venous varix is connected to the hematoma. The venous varix is away from the actual point of fistula. So this is a very important point to consider and understand for younger colleagues, that in dural AV fistula, the bleeding point is or can be and often is distal to the actual arteriovenous shunt. And in fact, there are in the literature cases of thalamic hemorrhage that looks exactly like what we would define as hypertensive hemorrhage in a patient with the dural AV fistula, where the fistula itself, the actual arteriovenous connection, is far away from the thalamus. So remember this concept. So going back to this patient has presented with the hemorrhage as a sizable hematoma. You can see here the once you know the location of the fistula, the feeders are also very predictable. These lateral tentorial dural AV fistulas are fed by distal branches of the meningo-hypophyseal trunk. You can see in this case, and you can see how this is the actual point of fistula. And on an angiogram where you try to understand where is the actual point of fistula, you follow the artery, the feeding artery distally. And when you see that, of course, the feeding artery, as it goes distally, tapers down and gets smaller and smaller. And when you see that there is a transition from a small artery to a larger vessel, i.e., the arterialized draining vein, that's where the point of fistula is. So you can see in this patient the point of fistula along the Petrus ridge, where the petrosal vein would be located, and the venous varix, which is the actual point of rupture, which is distal from the actual arteriovenous connection. And here you can see how you can trace this fistula, the arterialized draining vein, as we were seeing before on the CT angiogram. You can trace this arterialized vein which eventually drains probably through a superior Vermian vein, precentral cerebellar vein into the galenic system. So you can see you can trace nicely the arterialized draining vein. And this is an external carotid artery injection. And on the external carotid artery injection, these lateral tentorial dural AV fistula are often fed by branches of the middle meningeal artery. In this case, often it's the petrosal branch. And this is very important because when you use liquid embolic agents for embolization of this fistula, you need to be cognizant that the petrosal branch of the milomeningeal artery provides blood supply to the seventh nerve. So in this particular patient, we have a hemorrhage. We have the fact that the catheterization, if we are thinking about endovascular treatment, a distal catheterization because of the tortuosity and the small caliber of the vessel would be quite problematic to be able to get distal enough and obtain an effective occlusion of this fistula. On the other hand, the fact that we have a hemorrhage, we have a rupture point, so there is an area of weakness along that arterialized vein, and the risk of early rehemorrhage in a patient with a dural AV fistula with exclusive retrograde venous drainage and a venous varix, the risk of rebleeding over the first couple of weeks, it's actually quite high. And then, if you are thinking about how are we going to treat this fistula, and again, nowadays, whenever possible, we tend to favor endovascular treatment. But as I said, in this particular case, you have a hemorrhage with the hematoma. Would be nice to drain some of that hematoma. You have very small branches that would be very difficult to catheterize. And even if you get there, then you have supply from the petrosal branch, and as you inject the liquid embolic material that goes into that fine network, you might compromise the vascularity of important cranial nerves. So in this particular patient, there is little question the surgery was the correct and best therapeutic option. And you can see that the treatment of dural AV fistulas with exclusive retrograde cortical venous drainage consists of simple ligation, i.e. occlusion of the arterialized draining vein as it emerges from the dura. And we discussed about the fact that in dural AV, I cannot stress this enough, dural AV fistula, the site of rupture is often distal from the actual point of the AV shunt. And again, in this case, you can see the point of rupture was here, the fistula is here. So, as I said, this is a lateral tentorial dural AV fistula, and now I will show a couple of cases of fistulas in the same location to bring on the message that once you understand the location of the fistula, then the fistula might look quite complex on the angiogram, but the treatment can be quite straightforward. So this lateral tentorial dural AV fistula have exclusive retrograde venous drainage. As I said before, typically involve the superior petrosal vein system. This is another case, 69-year-old, presented with the history of imbalance and dizziness for 1 year, diplopia for 6 months. MRI shows a dilated vessel in a sparse distribution. When you see this picture on the MRI, immediately you should suspect dural AV fistula, because when you have an AVM, then the nidus, the vessels, are much more compact. When you have this picture of sparsely dilated venous channel, this is often related to a dural AV fistula. And you can see, remember what I said, once you understand the location and the concept, you can see immediately, you don't even need an angiogram in this patient. This patient, this is the point of fistula. It's along the petrous ridge where the petrosal veins enters the superior petrosal sinus, and this is the arterialized cortical, the beginning of the arterialized vein, and occlusion of the vein at this level will cure this particular fistula. This is the angiogram, external carotid artery injection, hypertrophic branches of the milameningeal artery going into the actual venous connection with an early varix. Here you see looks very complex, very intimidating, but once you understand, you will see the surgical treatment pretty straightforward. CT angiogram, it's very helpful because it will show you the actual point of origin of the arterialized draining vein, like in this particular case. You can see that this patient had undergone attempted embolization elsewhere. You can see the onyx cast. But again, many of these fistulas, unless you are able to get very close to the actual point of fistulization, they might be difficult to treat endovascularly. Plus, remember, you expose the patient to the risk of compromise of important cranial nerves. Here, remember what I said in the first case, supply of this lateral tentorial dural AV fistula, often from external branch of the milameningeal artery, particularly the petrosal branch, and the distal branches of the meningohypophyseal trunk, which arises from the internal carotid artery. So you see the pattern. This is the treatment. This is a retrosigmoid approach, and it's on the right side. So this is front, this is back, and you go for that point where the tentorium meets the petrous ridge, and you find the equivalent. Here it is, the equivalent of you can see the large arterialized vein, and here is the actual point of shunt. The point of shunt is within the dura. So you can see all these small arterial feeders converging into the arterialized draining vein at the point where the vein emerges from the dura. Here, ICG fluorescence shows nicely this fine network, which is the point of shunt, and then the large arterialized vein emerging from the dura, exactly like the CT angiogram had shown us. So you isolate the proximal portion of the arterialized draining vein. And then, as I said, here you see there is an early branching of this vein. And then the treatment is pretty straightforward. It's a clip ligation of the proximal portion of the arterialized draining vein as it emerges from the dura. You don't really need to do anything about that fine network, because once you close the outflow, the actual point of shunt might be still there, but you have closed the main outflow. So blood is getting in, has nowhere else to go, and the fistula is dead. Now, you might ask yourself, say, well, why, when you do that, if you do that, you close the vein in a parenchymal AVM, it's a disaster. The entire AVM will explode. You might ask yourself, why the same thing does not happen here? Well, the answer, it's rather simple. Dural AV fistula, the arteriovenous shunt, is within the dura leaflets. And if you consider the dura, the best analogy I've heard is the dura, it's like a carpet. The carpet is formed by two layers. And in between these two layers, like a sandwich, there are veins. So in the dural AV fistula, the actual arteriovenous shunt is within the two layers of the carpet. So you might close the vein, and the nidus is contained within the dura. That's the reason why it does not explode. And what happens is that, as I said, blood is coming in, you have closed the outflow, the fistula is dead. And this is another case. Again, I'm showing you these cases, particularly of this type of fistula, to bring home the message that once you understand the concepts, then the treatment, you understand the symptoms, you understand the angiogram, and that's, it's a nice example of how important is to be familiar with very basic concepts, and now knowing these very basic concepts will allow you to solve problems that, if you look at the picture, can appear quite daunting. This is another case, meningoepiphyseal trunk from the internal carotid artery, branches of the distal branches of the meningeal. The CT angiogram shows nicely the point of fistulization, and you go and do surgery, and it looks exactly like the previous case. Here is the junction of the tentorium with the petrous ridge, this fine network of arteries which converges into a single venous trunk. Treatment is rather simple. Clip ligation of the arterialized draining vein as it emerges from the dura. Pre, post, you see the dilated arteries are still there. Eventually, they will undergo involution because there is no more demand. And having occluded the outflow, you have closed the fistula and solved the problem. This is the follow-up on the previous lady that I showed, where we did the clip ligation. You can see the CT angiogram. There is still some degree of dilatation of the veins. You can see here the radiologists call this a hemorrhage, but this is not a hemorrhage. This is nothing but the thrombosis of the proximal portion of the arterialized draining vein where there was that venous varix. This is the MRI pre and after 6 months, and you can see the progressive involution of the dilated vessels and the changes over time in blood products of the thrombosed proximal venous varix. I will briefly pause here. If we have any, Maria, how would you like to do it? Maybe if we have some questions or comments, we can pause here and then restart with the presentation. I think that probably will make it more interactive. And if there is any point, any question, please feel free to ask. Believe me, these are problems and pathologies that even experienced neurosurgeons, unless they have a lot of experience with these lesions, might not necessarily be aware of some of the points that we have discussed. So feel free to ask any question, and or as I said, I spent a lot of time on those specific cases, because I hope that I can convey the understanding of some of the basic principles that will allow you to decodify and plan a safe and effective treatment for these fistulas.
Thank you very, very much, sir. Were amazing cases and everything. I guess everyone is so much intrigued. There's just one question in the chat box by now, by Dr. Uday Gupta. He's saying, sir, clip versus coagulation, which is better for closing of the outflow?
I don't think that there is one it's better than the other. The when I actually I usually, if possible, I combine the two. I place a clip, a permanent clip, and then I coagulate the vein behind the clip and then divide it. With some of these fistulas, I've had the intraoperative experience because the arterialized vein, especially if the fistula has been there for a long time, the arterialized vein can be heavily calcified. And I've had the experience of placing a permanent clip on the arterialized vein. And when you do the ICG fluorescence, there is still flow because the blades of the clip are not strong enough to close it. Experienced colleagues have also told me that when they use the clip alone, they've had the experience of the clip for the same reason, since the vessel is very hard and calcifies. They've had the experience that in the post-operative period, the clip has slipped back and the fistula was still open. So whenever possible, I try to coagulate and divide. There are certain situations where you don't have a good visualization of the vein distal to the clip, in which case clip alone it's fine. The other thing is that, as I said, you don't need to coagulate that arterialized plexus that is in the dura and that converges on the vein. But in some situations, I very gently with bipolar, I try to shrink that a little bit because it will soften a little bit the arterialized vein. But it's not necessary to coagulate those are fine arterial network. And one of the reasons to try to avoid that, to coagulate it, is that if you start getting bleeding from those fine arteries, it's not always easy to control because they are really flush with the dura.
Thank you very much, sir. Sir, that's a very huge and very elaborate answer, sir. You have addressed so many things and so much clearly, sir. Everyone is appreciating that. There is another question, sir, here. Tentorial dural AVFs are usually treated with one or multiple surgical sessions. Sir, Dr. Ali Mokashar wants to ask that whether tentorial dural AVFs are usually treated with either one or multiple surgical sessions.
Well, the dural AV fistulas that have like the lateral tentorial ones that have exclusive retrograde cortical venous drainage. The treatment is occlusion of the vein as it emerges from the dura. So it's usually a single surgical session. And I see a question about embolization, pre-surgical embolization. I would say that it's not uncommon that we try to treat a fistula with embolization first, and then we go to surgery if the embolization is felt to be not safe or if the embolization fails. But pre-surgical embolization would be would be helpful in those dural AV fistula of the transverse sigmoid sinus to try to devascularize a little bit the supply and help a little bit with minimizing blood loss during exposure and during the craniotomy. The truth is that nowadays those transverse sigmoid sinus dural AV fistulas are rarely treated with the surgery. So pre-surgical embolization, at least in our practice, it's not used for dural AV fistula, while as we know, it's a very good practice for parenchymal AVMs.
Sir, thank you, sir. There is something that in my mind. So there is the technique of skeletonization. So when would you go for skeletonization? Have you proceeded with the skeletonization of the sinuses, where you just operate at?
Yeah, if when the cases that we have seen so far, those are dural AV fistulas without involvement of a major sinus. When there is involvement of the major sinus, so it's usually transverse sigmoid, torcular, or superior sagittal sinus. So in those cases, one of the treatment is skeletonization of the sinus, disconnection of arterialized draining veins, and usually that coupled with packing of the sinus or ligation, the packing with different materials or ligation of the sinus. But that's usually for transverse sigmoid sinus or superior sagittal sinus dural AV fistula.
So there is like some factors like post-surgical and post-interventional hemorrhages that may take place after you have operated on sinus and on the fistula, and there are some factors that can actually through which we can actually have some idea that this might lead to a post-surgical or post-interventional hemorrhage, such as the I've read that there's some bile could be a supply from the bile vasculature. There could be like diffuse CVR instead of focal CVR that could be there, or things like that. And obviously the venous aneurysm. So, sir, there is anything that you would like to have in your mind, to keep in your mind, to predict the complication that might happen, and then you have to plan and tailor your approach accordingly and manage the whole case on a case-to-case basis. So would you have any plan for this complication to avoid this complication and to undergo like in the case of pre-embolization or failed embolization that might have taken place at any other place and they had left to incomplete obliteration and you are just having this type of complication that might take place. So would you like to tailor your approach accordingly and plan accordingly? How would you proceed with it?
So I think that of course you can have complications. One of the fear complications in a dural AV fistula treatment or also in like in parenchyma AVMs is that you close the arterialized draining vein and the remaining portion of the arterialized draining vein, as I shown in the last case, eventually will undergo thrombosis to the next point where the vein participates to the drainage of the normal brain. So one of the possible complications is that you fear that that thrombosis might extend to some of the veins that are still helping drainage of the brain. In these situations, you can have postoperative edema or postoperative even delayed hemorrhages. I must say that that complication it's likely not that common. As far as your comment about the PL supply, yes, it's true that some dural AV fistula can have PL supplies. We used to say it, the dural AV fistula are fed exclusively by arteries that provide supply to the dura, but it's not that uncommon that the fistula itself might recruit some very fine distal vessels from PL supply. And in those cases, those are the cases where we will consider that a contraindication to embolization, because the principle that I've shown, when you close the arterialized dural AV fistula, if you have a true PL supply, might cause hemorrhage from persistence of AV shunting from those PL network. While of course, when you do it under direct visualization, you can carefully coagulate some of those vessels. Now, it is also true that what sometimes we perceive as a PL supply is not true PL supply, but is instead supply of the fistula from dural vessels, which originates from vessels that for the most part supply the brain. For example, doing seeing a lot of dural fistulas, we have learned that there is and it has been reported not too long ago, that there is, for example, a fairly consistent branch of the superior cerebellar artery which goes to the tentorium. The same way, there are distal branches of the posterior cerebral artery, which we know very well, that supply the tentorial incisura around the area of the galenic system. The same is true for the posterior inferior cerebellar artery. Does have a very small dura branch that sometimes you see when you do a posterior fossa decompression. You open the dura, and often you see a tiny little branch from the pica going through the arachnoid to the dural supply. So yes, there can be dural supply, PL supply to dural AV fistula, but sometimes what we perceive on the angiogram as a PL supply, it's indeed supply of distal vessels to the dura from arteries that for the most part supply the normal brain.
Thank you very much, sir. Sir, I think that everyone is so much intrigued, and
Okay,
there
we
so
can
much info. Yes,
resume
sir,
the
sure, sir.
presentation.
Yes, sir. Sir, they are so much enthusiastic. I think they are so much excited. The questions are coming up. We can take the rest of them after it as well, sir. Again, thank you very much, sir. It has been so elaborate discussion with you. Thank you so much. Please resume.
So this is another case of a patient who presented with hemorrhage. So the patient present with, going back to our original discussion, when in choosing a therapeutic approach, of course, the patient presents with the hemorrhage. As I said, is at risk of recurrent hemorrhage, and therefore, that particular patient, if at all possible, requires a therapeutic solution which leads to immediate complete occlusion of the dural AV fistula. This is another type of, so remember, the lateral tentorial dural AV fistulas. Then there is another subtype that is pretty much close to the midline, and those can be anterior and thus involve the galenic system, or they can be posterior, and they involve some of those veins that are bridging veins that are immediately off to the midline. And then there is another subtype that I think it's less common, where the involvement, the arterialized vein, it's one of those paramedian veins going from the cerebellum to the tentorium, or from the base of the temporal lobe to the upper surface of the tentorium. So you can see this patient presented with sudden headache and has a small supratentorial hemorrhage involving the posterior temporal lobe, And here you can see the onyx cast, because this fistula was treated with onyx embolization. And you can make here the slope of the tentorium, and you can see that the onyx cast occludes the proximal portion of a draining vein, which from the tentorium was draining from the base of the temporal lobe into the tentorial plexus. This is a beautiful um, picture that shows what we were discussing before. How do you identify the actual point of fistula? This is the microcatheter. It's in a small branch of distal branch of the milameningeal artery, and you can follow the onyx cast. And what we were saying before is that the point of fistula is where the distal small arterial feeders tapers, and then all of a sudden you see the transition to a larger vessel. So this is the proximal end of the draining vein, and this is the distal portion of the feeder, and you can see here this the communication. Now, of course, this is just one example of communication. When you have this dural AV fistula, there are many micro AV shunts, which eventually, in this type of fistulas, drain into a single draining vein. So this is a case where another lateral tentorial dural AV fistula patient presenting with continuous facial pain, because the arterialized vein, if you recall the relationship of the petrosal vein with the fifth cranial nerve, the venous varix was impinging upon the trigeminal nerve. In this particular patient, if you can see on this picture, here is the tip of the microcatheter. So in this particular patient, we were able to navigate with the microcatheter into the actual proximal draining vein. So we felt that we were distal enough and in a position where we could be able to close this fistula safely with the liquid embolic agent. Here again, the CT angiogram on this patient. Remember, when you see this pattern of sparsely dilated venous channel, think dural AV fistula. On the CTA in this patient, you can tell this is the point of fistula. You can see the dilated arterialized draining vein as it emerges from the dura along the petrous ridge, where you would expect the superior petrosal vein. And again, injection showing milameningeal artery supply to the fistula. We were able to trade. The milameningeal artery runs into the dura. So it's a fairly straight artery and is the best friend of the interventionalist, because being straight, you can catheterize the artery very distally. And of course, in a patient with the dural AV fistula, those channels, they tend to be larger than normal. Here you can see a nice depiction of the petrosal branch of the milameningeal artery draining into the arterialized draining vein and the varix that you saw on the CT angiogram. And here you can see nicely the connection. So with the microcatheter, we were able to go actually through the AV shunt into the proximal vein. And that's, of course, is the best possible position, because with embolization, you can do what we would have done with surgery, which is occlusion of the proximal portion of the draining vein. And here you can see the progressive onyx cast filling the network around. Remember the network that we saw at surgery, which converges into the proximal draining vein. Here is that network and beautiful depiction of a onyx cast, which correlates with the angioarchitecture of the fistula, if you remember that picture that we saw in the video during microsurgical occlusion. And once again, supply from branches of the meningeal artery and distal branches of the meningo-hypophyseal trunk. So you see how there is a pattern that is fairly consistent, even though, of course, the morphological expression can be quite different. We'll switch gear now and consider different types of dural AV fistula, but again, here the goal is to try to convey with examples some basic principles to keep in mind. As you recall, I said that since the pathophysiology of dural AV fistula is a compromise of the venous outflow, the venous drainage, then fistulas can present with all kind of neurological symptoms or signs or different combinations known to mankind. And there are fistulas, especially if they involve the primarily or secondarily, they involve the superior sagittal sinus or the deep system with involvement of drainage from both thalami. These fistulas can present with the progressive cognitive decline, which clinically can be very difficult to distinguish from the much more common forms of primary dementia. This is a 52-year-old who had a progressive cognitive decline. And you can see in this patient is that the fistula is fed by branches of the internal maxillary artery. Here is the fistula. The fistula is around the sphenoparietal sinus. So this is a sphenoparietal sinus dural AV fistula. But you can see that as there is an arterialization of the sphenoparietal sinus and the secondary arterialization of Sylvian vein, then there is a secondary involvement, or you can see here, of the superior sagittal sinus. So the superior sagittal sinus is partially arterialized because it's providing a drainage to these arterialized veins. There is, and therefore, there is a delay of the outflow from the entire brain, hence the picture of a global dysfunction and progressive cognitive decline, which mimics the more common degenerative disease. And here, as I said, this can be quite daunting and intimidating, but once you understand that everything is converging into a vein, and that vein must emerge from the dura, the treatment is pretty simple. This is nothing but a small pterional craniotomy. What you are looking here, this is the dura, and you can see that has been charcoal because there were all these large feeding arteries converging into a single draining vein, which from the dura, here is the dura that has been opened and flipped, and this is the Sylvian fissure. So this is a vein that from the sphenoparietal, from the Sylvian fissure was draining into the sphenoparietal sinus, which is arterialized, and occlusion of this vein with the surgical clip, I will show you, will resolve this complex fistula. So again, dural AV fistula with exclusive retrograde cortical venous drainage can appear quite complex on the angiogram, but once you understand, based on the location, the knowledge, and you understand the pathophysiology and the pathological anatomy, the treatment is fairly simple, and it's occlusion of the proximal portion of the arterialized draining vein. And here, if I can, you can, I, I thought I had the video, but the treatment would be just to place a clip. Oh, here it is. So you can see here the Sylvian fissure, the dura, just place a clip there, and that's the treatment of that complex dural AV fistula. Now here is, as I said, I am showing surgical examples, because with the surgical examples, so we can have the video, so we can actually look at the fistula the way they appear in vivo. But the vast majority of dural AV fistula nowadays are treated with endovascular embolization. And this is a complex case, an example of a complex, very complex case. This is a tentorial dural AV fistula, medial tentorial dural AV fistula, anteromedial. So these are also defined as a galenic type. This patient, you see, presented with the obstructive hydrocephalus, probably from combination of obstruction of the aqueduct with increased venous outflow. And here is the picture. So once you understand, so this can be very complex supply from middle meningeal and posterior cerebral artery branches. Once you understand that complex, that everything is converging into a single draining vein, then you can devise a treatment. And this is the endovascular setup. So here the strategy was to go inside the fistula if possible, place some coils so that the coils will trap, because if you start injecting a liquid embolic agent like onyx, glue, or fill, the material, there is such a arterialized flow that the material will be pushed out, will fly distally. But by creating a basket of coils, the coils will trap the material as you occlude the proximal portion of the draining vein. So here with the microcatheter, we were able to go through these dilated arterial channels. Here you can see this is a transvenous approach now. So we have a catheter very close to the point of fistula. This is a catheter that through, in a retrograde fashion, through the veins, we are trying to reach the venous pouch, so we can partially fill that with coils, and then follow with the embolic agent to achieve complete obliteration. This is a venous injection, and now we're putting coils. And now with the coils in place, we will inject the onyx, and you can see how the onyx stays inside the proximal portion of the draining vein, some reflux. And you can see now the onyx starts filling some of those arterialized venous channels, and now you can see that progressively filling the proximal portion of the arterialized draining vein. And you can see that how as the embolization progressed, there is still residual fistula, but it's much slower, much less filling than before. And you can see that was the final result. We didn't, in this patient, I think we were hoping that with the treatment, the hydrocephalus would get better, did not get better with treatment, so we end up also placing a shunt, but she did well. Sometimes you deal with the fistulas that are so daunting that no matter how much experience you have, it can be very difficult to understand what's going on. And in some cases, to do something to palliate, to improve the symptoms without necessarily close the fistula is a reasonable compromise. Is a 42-year-old with Down syndrome with a progressive gait impairment. As you know, with Down syndrome, it's not uncommon to have atlanto-occipital instability. This patient, we did the flexion extension films, did not show instability. You see that there is some edema or T2 changes at the level of the craniocervical junction with some dilated flow voids. And here is a massive fistula, maybe more, this patient, more than one fistula. You can see these are branches of the external carotid artery that are larger than the internal carotid artery, which is also providing supply to the fistula. And you can see that in this case, we had a multi-stage approach where we close some of those huge external carotid artery feeders, partial occlusion of the fistula. We were unable to occlude the fistula completely, but we were able to slow down the flow enough that there was less engorgement, and you can see that 1 year follow-up, there is resolution of the T2 changes, resolution of the swelling on the spinal cord, and look how much space is now between the cranial cervical junction and the posterior fossa bone, nice lake of CSF. So the patient symptoms almost were completely reversed. The fistula still there, but we were able to improve our quality of life, and the fistula still there, but we didn't feel that we had the safe option to cure that fistula. This is an example of a ethmoidal dural AV fistula. It's another type of fistula that has always exclusive retrograde cortical venous drainage. There are, of course, these are typically fed by ethmoidal branches of the ophthalmic artery, and there is secondary involvement of the superior sagittal sinus. Commonly, these present with hemorrhage, but they can also present with, like the previous case, since there is involvement of the superior sagittal sinus, they can present with cognitive decline as well. But once you understand that these fistulas are typically the arterial, they might have bilateral supply, but the arterialized draining vein typically emerges from the dura immediately off the midline along the crista galli. So this is a case where we did a frontal craniotomy. You can see the arterialized cortical draining vein. We follow, this is the midline, we follow the draining vein down. You see the dura of the falx, and as you approach the base of the falx, close to the crista galli, you see that fine arterial network inside the dura with a large arterialized draining vein emerging from it. Here's the ICG fluorescent. So once again, once you understand the combination of the location angioarchitecture, the appearance, it's pre-standard, and those are also treated very well with the surgery. We were a little bit careful with the endovascular approach to this anterior ethmoidal dural AV fistula, because usually the main supply is from ethmoidal branches of the ophthalmic artery, and there was a concern about compromise of vision from reflux or from any complications. But endovascular techniques have improved to the point where now in the literature you see more and more of this anterior ethmoidal dural AV fistula being treated also very effectively with endovascular treatment. I will close with a case of a transverse sigmoid sinus dural AV fistula. This is actually the most common type of dural AV fistula which you will encounter in your practice. Transverse sigmoid sinus dural AV fistula, you can schematically subdivide into two types: benign and dangerous. The vast majority are benign. What does that mean? That means that there is no retrograde cortical venous drainage. The symptoms in this benign type are related to hyperflow. Like a patient, usually they have a bruit that can be disabling. It's amazing that from the clinical exam, you can often diagnose these fistulas, because the patients will tell you that without knowing what's going on, they often learn some tricks. They will tell you that if they press on the mastoid, they've noticed that they can make the bruit better. And you say, okay, what's happening there? Or if they can make it worse if they turn toward the same side, or they can make it disappear if they turn the neck all the way to the opposite side. So it's funny to see how patients, without knowing much about these fistulas, they learn a lot. Well, why some patients notice that pressing on around the mastoid, they can make the bruit better? Because the main supply to this transverse sigmoid sinus dural AV fistula, it's from transosseous branches of the occipital artery. So by pressing in the mastoid area, basically the patients notice that by pressing the occipital artery, they can decrease the flow and they can make the bruit better. Of course, they don't know about all of, but they will tell you, because it's funny how people can learn and can notice. Now, why turning on one side, it can make the bruit better or worse? Well, because if you think about the primary secondary drainages from transverse sigmoid sinus junction down internal jugular vein, and by turning on one side, you can twist and virtually close the ipsilateral internal jugular vein. And by switching the drainage to the contralateral side, you make the bruit better. So you see, like, the other thing about these fistulas and clinical exam is that a friend of mine, a neurosurgeon, told me, I learned that if a patient comes in and you suspect a transverse sigmoid sinus dural AV fistula and they have a bruit, if you put a stethoscope on their mastoid, you will hear a bruit. If you don't hear a bruit, it's not a transverse sigmoid sinus dural AV fistula. So you can easily, in this patient, hear a bruit if you put your stethoscope on the mastoid where the transverse sigmoid sinus junction lies. So those are the vast majority. They are not dangerous because they don't have secondary retrograde cortical venous drainage. So in these patients, the strategies that is to treat the symptoms. So you can decrease the flow without completely cure the fistula and have a happy patient because you can take of the care of the brewing. Now, there are a variety of different strategies that you can imply in these fistulas. You can see here is a typical transverse sigmoid sinus dural AV fistula. There are so many tiny little vessels converging into one point that it's very difficult to make out the precise angioarchitecture in these fistulas. But look at this occipital artery. The size of this occipital artery is almost the same as the internal carotid artery. So you can see how people can learn that if you press in specific areas, they notice that they can make the bruit better. I will not go into all the different potential strategies. Here at Mayo, we have almost a unique way to deal with these fistulas that in our experience is extremely effective. And we're just publishing our results with this strategy in more than 260 patients will be published soon, I think, in Journal of Neurosurgery. So what we do is we do transarterial PVA embolization. And PVA embolization is particle embolization. And you know, or you will learn that particle embolization is almost by definition not curative. You can decrease the vascularity, but you cannot penetrate with particles. Unlike liquid embolic agent, you cannot penetrate the fistula to a degree to be able to effectively occlude the proximal portion of the draining vein. But we do transarterial embolization, PVA embolization, with the idea that we like to palliate the symptoms. Now, you might hear that if you use particles, you get complications because you have anastomosis between the external carotid artery and the internal carotid artery, anastomosis between branches of the external carotid artery like the occipital artery and the vertebral artery. And therefore, if you inject particles, the particles can go through this small anastomosis and you are embolizing the occipital artery and you might end up with the posterior circulation stroke. But if you know well the anatomy and the angioarchitecture of these collateral pathways, you should know that usually the size of these vessels is less than 150 microns in diameter. Therefore, by utilizing particles that are larger than 150 microns, we prevent migration of the particles through the dangerous anastomosis. So that's why it's important that if you use particles with this type of strategy, use particles that have diameter greater than 150 microns, and then it becomes a very safe embolization. It's external carotid artery embolization, and we combine that with the gamma knife. The goal of the embolization is twofold. Number one, it's practical. You decrease the blood supply right away, and the bruit improves or often resolves for a period of time. The second reason is a little bit more theoretical, and is that maybe by shutting down a significant portion of the arterial supply to the fistula, we might help the gamma knife to be more effective. And as I said, this is a strategy that we have applied for a long time, and we are in the process of updating our early experience, which was published now almost 30 years ago. And you can see nicely that with this strategy, usually after a year, because as you know, the gamma knife takes some time to work, you can get a nice resolution. And more importantly, with this strategy, you're also able to preserve patency of the venous sinus. So when we look at our experience, and this was now a few years back, in terms of treatment, we use a single therapeutic modality in 60% of cases. Observation, as I said at the beginning, it's a valid option. And often it's a combination therapy. In our hands, it's when we say combination therapy, it's for dural fistula, it's usually embolization followed by stereotactic radiosurgery. And you can see here is the breakdown. We used overall embolization, 77% of patients, radiosurgery about 1/3. These are almost exclusively transverse sigmoid sinus dural AV fistula and indirect CC fistula. I didn't have the chance to stress the fact that if you consider carotid cavernous fistulas, there are two types, as you know. The direct type is a completely different problem. It's related usually to an aneurysm, rupture of the intracavernous carotid artery from trauma or spontaneous rupture in patients with connective tissue disorders like Ehlers-Danlos. And then there are the more common indirect CC fistula. The indirect CC fistula, it's nothing but a specific type of dural AV fistula. So I don't know why, but stereotactic radiosurgery, it's very effective for transverse sigmoid sinus and for indirect CC fistulas. It's not so effective in some of the cases I shown of tentorial dural AV fistula or ethmoidal dural AV fistula or sphenoparietal dural AV fistulas. I will finish with one more example. This is a craniocervical junction dural AV fistula. These are dural AV fistulas that tend to have a lot in common with the dural AV fistula of the spine. This is a patient with progressive myelopathy, and this is actually a large arterialized draining vein. It's not directly connected to the vertebral artery. There is an arterial network. And this particular patient, you see that on the posterior circulation injection, you notice that there are leptomeningeal collaterals to the middle cerebral artery. And this is because this patient has also what is it's defined like a twig-like MCA, where the proximal MCA is occluded, but the distal portion of the MCA is reconstituted through a moya-moya-like network. This patient does not have moya-moya because the supraclinoid internal carotid artery and the contralateral side, which I will not show, it's normal. And we have reported 4 cases, interestingly enough, were all patients from the Far East with this combination of intracranial steno-occlusive disease and dura AV fistula. And you wonder if there might be some kind of pathophysiological common pathway or link between the two. Going back to our craniocervical junction dural AV fistula, again, can be at the beginning a little bit to understand exactly what's going on the angiogram, but once you explore, there is a typical pattern. So here is far lateral approach. This is up. This is this is superior, this is inferior toward the spinal cord. This is a right-sided approach. So we open the dura. You can see the tonsil, and you can see the vertebral artery as it emerges from the dura. And in these cases, the arterialized draining vein, typically, you see here, the arterialized draining vein typically emerges from the dura immediately adjacent to the point of entry of the vertebral artery. So here we are tracing down that arterialized draining vein. You can see here as the arterialized draining vein as shown on the angiogram, then drains down toward the spinal cord on the dorsal aspect of the spinal cord. Here you can see that we are monitoring somatosensory potential. So that's why you can see how the frame is shaking because of the stimulation from the somatosensory potentials. Here we are following that arterialized draining vein from the point of emergence from the dura. And again, you can see the commonality. And once you are identified that point, treatment again pretty straightforward. And you can see how the vein collapsed. This is it's another case, again showing the commonalities. This is the pica, craniocervical junction, right-sided approach. And here is the arterialized draining vein emerging from the dura, very close to the point of emergence of the vertebral artery. This is the case I was mentioning before. It's a long-standing fistula, so it's extremely calcified. And you can see that even with the ICG fluorescence, you see the early filling of the distal vein. But remember, ICG fluorescence is like a calcified aneurysm. You don't see very well the early filling of that calcified here. This is a calcified, extremely calcified arterialized vein. This is the case I mentioned before where placing the clip didn't really do much. This is a distal portion of the arterialized draining vein. You can see draining toward the and here you can see there is a clip on the proximal portion, but the vein, distal vein, still looks arterialized. And then eventually, in this case, I had to place another clip on the most distal portion of the vein because the proximal clip was not enough. And now you can see that you see filling of the vertebral artery, the pica, but you don't see filling of that vein along the dorsal aspects of the spinal cord. So again, to bring home the concepts, craniocervical junction, dural AV fistula, they might have different appearance on the angiogram, but the angioarchitecture, the anatomy is fairly consistent. There is an arterialized draining vein which emerges from the dura parallel to the point of entrance of the vertebral artery. And thank you very much. So I hope that I was able to convey some of the basic principles underlying the pathophysiology, clinical presentations, and some of the treatment principles for dural AV fistula.
Thank you very, very much, sir. It was a very wonderful and very detailed talk. And like I can see Professor Vargas was here and he was saying that you have made it look so very like you have make an like an abstract of everything which is very complicated, but you have conveyed your message so nicely. I think we are all, especially the young neurosurgeons, are so lucky to have teachers like you around who are so much dedicated to share their knowledge and their experience with us. So again, sir, thank you so, so much. And I think you have completed your slides with the CVJ AVF. I think it was a very I've been wondering that it was a very interesting topic for us as well. I think the CVJ AVFs are more treated with more treated surgically. They are, I guess, they are more a surgical lesion than for the endovascular. I don't think they should be considered for the endovascular ones. So it was something it was my mind as well to bring about in the discussion session, but you have also elaborated it, sir. There is also something that was in the comment section, I guess, that there, sir, we have got tons and tons of questions in the comment section already, and many of
I
them.
see some, maybe I can answer some. So one question is how many thalamic bleeds at fistula in my experience? Well, I mentioned that example of a thalamic hemorrhage from a fistula because it's reported in the literature. But of course, you don't need to look for a fistula in every single patient who comes in with the thalamic bleed. When there is a fistula, if you do a CT angiogram or an MRI in any of these patients, you might have hints, indirect hints that there is a fistula because there are some dilated flow voids. But if you have a patient who comes in with the thalamic bleed, it's a relatively young patient, or there is no clear-cut history of hypertension, I think that's like anything else. It's one of those things to keep in the back of your mind. And if there is a suspicion based on clinical and some of the non-invasive imaging on the angiogram, it's important. You know, the classic teaching is that when you are looking for a vascular cause, the angiogram must be a six-vessel complete angiogram, including both external carotid arteries. But of course, this is not, I mention as an extreme case, but I definitely will not recommend to look for a fistula in every patient with the thalamic bleed. There is another question about pre-surgical embolization required. As I said, usually don't consider pre-surgical embolization for the fistulas with exclusive retrograde cortical venous drainage, but we do consider pre-surgical embolization if we are planning to treat a more complex fistula, such as transverse with surgery, such as transverse sigmoid sinus, or there are some superior sagittal sinus fistulas that are not true superior sagittal sinus, but are paramedian. Basically, they involve a vein draining, the shunt involves a vein draining into the superior sagittal sinus. Those can be supplied by hypertrophic branches of the milameningeal artery. Sometimes we would consider pre-surgical embolization. I don't think the pre-surgical embolization in these cases is done just to help a little bit with the craniotomy and minimize the risk of excessive blood loss. So I don't think that there is a specific time. Usually we tend to do the day before.
Sir, sir, regarding the presentation, there is also a couple of case reports that have been reported that the patients have been treated for BIH and later on discovered to have dural AVF. So, if we provide the fact that we believe that BIH, the benign intracranial hypertension, can be caused by like CVSTs and always the venous signs thrombosis and also the stenosis. So if we say that those patients have been mistreated, have been misdiagnosed to have a BIH, and later on go on to develop were later on, like they were first misdiagnosed to have a BIH, and later on it was discovered that they had a dural AVF. It provides the fact that if we believe that the cause of both dural AVFs and BIH can be like a sinus thrombosis or sinus stenosis, can we believe that initially they also had a BIH and later on they had developed this type of dural AVF? So this is also in question in the chat box, because there have been a couple of case reports that have stated that the patient was misdiagnosed with a BIH and later on it was discovered that he had a dural AVF.
Yes, it's definitely possible. We know now there is an association between sinus thrombosis and dural AV fistulas. So it is possible that those patients might not necessarily be misdiagnosed, but they started with increase intracranial pressure secondary to the sinus thrombosis, and then the fistula came later as part of the evolution of the sinus thrombosis. Another thing to keep in mind is that, and that's also very well recognized and reported, is that actually transverse sinus thrombosis is not that uncommon after posterior fossa surgery. If you think about, we exposed the transverse sigmoid sinus junction with tend the dura up, so we compress the sinus. These operations, they might take a few hours, during which just the light of the microscope, the eye temperature, the sinus gets dry and heated. It's compressed against the bone, so it's not uncommon to have thrombosis of the sinus, and there are now many cases of dural AV fistulas which developed as a result of delayed complications of posterior fossa surgery. So it's always hard to tell which one came first in a patient with benign intracranial hypertension, but it is possible that was not necessarily misdiagnosed at the beginning. The fistula might have come later.
And so there's also some reports that the COVID-19 pandemic has led to an increased number of dural AV fistulas coming into light, especially those people who have been vaccinated and they have suffered from CVSTs. So there's also there are reports, although they need more time to be more accurate to prove the point is true, but they are saying that COVID-19 and vaccination could be another cause of dural AVS, because there's a bloom of diagnosis of dural AVS after the pandemic of the COVID-19. So do you believe it could be something that is very much relevant?
I think there might be something, because there's been an association between vaccines and venous thrombosis. And we know that the pathophysiology of some of these fistulas, not all, but some, especially the ones that involves the large sinuses, is related to a prior venous thrombosis. So that I think that there might be a connection.
Thank you very much, sir. Sir, there's a question. Is it possible to apply the same surgical principles for the spinal AV fistulas? Professor Gabriel Givergas has asked
Yes,
this question.
yes, the true spinal dural AV fistula, the so-called type 1 in all the classifications, those fistulas are treated exactly with the same principles of the intracranial dural AV fistula, with exclusive retrograde venous drainage, i.e. the treatment is the occlusion, the exclusion of the proximal portion of the arterialized draining vein as it emerges from the dura. So the treatment principles are very similar with the true type 1 spinal dural AV fistulas.
Thank you very much, sir. Sir, there's also, I think there is, obviously there is a consensus. It is very proven that the low grade fistulas they're supposed to be kept under observation and followed up, and the patient should be told if there is any change in their symptom. They should contact, even the disappearance of a bruit could signify that there is a change or an up conversion of the dural fistula. Sir, but there are also, obviously everyone tries to spark a debate, and although it has been proven that it's of no use, but do you believe that there should be any case where a low grade fistula should be considered for any type of intervention, whether an endovascular or a surgical intervention? Do you believe, is there any condition where you would go on to treat a low grade fistula without CVR?
Yeah, I think in a young patient where you see a high flow fistula, we know that the high flow fistula causes a high flow venopathy. So some of these patients, you can already see that there have been some morphological changes involving the internal jugular vein with some stenosis. So in those patients, I think that there is a place for consideration of treatment. Of course, you have always to balance that consideration for treatment with what are the potential risks. And when I say potential risks, I don't mean immediate complications. We also need to be mindful of the potential long-term complications. For example, in our series of patients treated with the stereotactic radiosurgery, granted it's a large series, almost 300 cases, granted the vast majority of patients were usually older, in the 60s, in their 70s. But in that series, we have had a delayed meningioma and one patient who developed after 8 years a cerebellar glioblastoma. So, even something that we would think stereotactic radiosurgery for dural AV fistula is very benign, because really what you are radiating, it's not the brain, it's the bone, because the sinus runs into a sulcus in the bone. And then of course embolization, it's very safe, but every series has a low single digit incidence. So yes, I know it's a long answer, but I wanted to stress a few points that yes, I would consider treatment, but always in some low-grade dural AV fistulas, especially if a patient is young and I'm worried about the long-term effects of high flow in developing delayed high flow venopathy.
Thank you for sir very much, sir. It's basically, it's so kind of you that you are sparing a lot of time for neurosurgical education. I know you are such a busy surgeon, and I know it's very early, so it's like we are obliged to you for all this elaborate talk and for the discussion, that the special time you have allocated for such a lengthy discussion, because I think it is so much priceless to have this opportunity of learning from you. So again, sir, thank you very, very much, sir. Sir, I believe can be like factors such as sir, hypercoagulability or something like this, and some patient that should be taken into account when making such decisions. So do you believe that that could be something that we should also take into account, that could not only affect our surgical risk, but also the risk of a conversion or something like that, those systemic comorbidities that might affect both the surgical risk as fast as the risk of up conversion? Do you believe that this, I think this is a very whole considering a patient as a whole, considering everything at each and every level. So again, sir, thank you so much. I think we have taken a lot of your time.
Well, it's been a pleasure. Thank
So
you.
thank
Thank you for the invitation.
No, sir, honor and pleasure is all mine. I was so excited, so much eager, and sir, I really wish to request you to to deliver your lecture again someday, whenever it is possible for you, whenever it is convenient for you, because again, sir, it was a huge privilege for me and for everyone who was here today to learn directly from you, especially on such an important topic, which is, frankly and honestly, I tell you that it has not been discussed so widely, especially in many of our hospitals. Many, it's like I've been so honest, many surgeons do not have that much of an insight, and it's like a privilege to listen from the masters like you. We like it's like very surreal, because we usually read your work and read about your work from the book, so it's like watching some hero coming into life resume. So it's a huge privilege. I again wish to thank you very, very much, sir.
Hey, thank you. You're very kind. We'll do it again.
Thank you so much,
Bye.
sir. So kind of. Bye, sir. Thank you, everyone who has been here. I hope that all of you have received your quiz link. It is a non-rated quiz. You just have to submit it in order to receive your certificate. It will be emailed to you directly in your mailbox. So just to submit this quiz and to receive your certificate. Again, thank you very much for joining it. The recording is available on my YouTube channel. You can go through it again and again as many times as you want. And I'm looking forward to welcoming you again to two of the webinars, including one that I will deliver myself on 31st of May. I will be delivering something on women in neurosurgery. I will be sharing my own experience, and I hope that you will all be interested in listening to what my experience is in neurosurgery. And I think I will try my best to help more women neurosurgeons who are um, who are of my age, especially, and who are my juniors, and all the girls who wish to join neurosurgery. So I really wish to invite you all to join my talk on 31st of May. It will be hosted at the Madall platform. I will be sharing the details. Let me share it with you. Okay. Uh, uh, so here is my talk on 31st of May at 2 p.m. British Standard Time. I hope to see you all at this talk. It is being hosted by newsman.org. It's an organization of neurosurgeons, mentors, and mentees, and they are introducing some really good concepts of mentorships. So please do join me as I deliver my talk on women in neurosurgery. I hope you all feel very, especially the women will feel so much connected to share all these experiences with each other. And I hope it will help all the young neurosurgeons, all the females who wish to join neurosurgery. And I think I will give you some realistic view, and basically I wish to promote more girls to join neurosurgery, especially those who are enthusiastic about it. We need more neurosurgeons who are enthusiastic and passionate about neurosurgery. So I believe that it could be very helpful and very insightful. I'm also sharing you about a talk with Professor Pascal Jabor that will take place on June 7th. Please do join that talk as well. You will be able to learn a lot from someone as legendary as him. So thank you very much again for joining today, and have a nice